Hello students! Welcome back to our chapter Concepts of Care for Patients with Problems in the Biliary System and Pancreas. And now, this is part 3 of the chapter. Before we discuss cholecystitis, I did part 1 and part 2. We have a technical issue, but we solved it. So that's why you have part 1 and part 2 for cholecystitis. And now we are moving to acute pancreatitis. Remember that your biliary system is composed by the liver, the gallbladder, the pancreas, okay? So before we get deep into the acute pancreatitis, always is good to watch the video to understand much better this condition. Short video.
Acute pancreatitis. Acute pancreatitis is the sudden inflammation of the pancreas. It can be very painful and usually means a stay in the hospital. About 5% of cases are life-threatening, usually when other organs are involved. The pancreas is a digestive system organ that has two important functions. It produces enzymes to break down food in the digestive tract, as well as hormones that regulate blood sugar. In acute pancreatitis, the enzymes used to break down food become activated before they leave the pancreas. These enzymes are so powerful that they start to attack and digest the pancreatic tissue. This process is called autodigestion. The most common causes of acute pancreatitis are heavy alcohol use and gallstones. Other less common causes include abdominal trauma, medications, infections, tumors, and genetic or anatomical variants. High triglycerides or high levels of calcium in the blood are also linked to acute pancreatitis. In some rare cases, the cause is never discovered. Attacks of acute pancreatitis are usually sudden and characterized by intense pain in the center of the upper abdomen, between the belly button and the chest. The pain radiates to the back. Sometimes the pain can be on the left or right side, or even lower down in the belly. Most people also have nausea and vomiting, and in some cases, fever. Blood tests for pancreatic enzymes can diagnose acute pancreatitis. The pancreatic enzymes that are typically elevated when patients have acute pancreatitis are called amylase and lipase. Diagnosis is usually confirmed by a CT scan. On occasion, MRI or ultrasound may be used. The radiologist will look to see if the pancreas is swollen or if there is abnormal fluid around it. Most people who develop acute pancreatitis are out of the hospital in a few days. However, about 1 in 10 cases are serious enough to affect other organs like the kidneys and lungs, and may require a longer stay in the hospital. Sometimes patients have to be treated in the intensive care unit. In very severe cases, surgery may be required to remove inflamed parts of the pancreas. If the cause of acute pancreatitis was related to gallstones, the gallbladder is removed surgically. As well, in some patients, the pancreas becomes so damaged that it no longer functions properly to make digestive enzymes. This is called pancreatic insufficiency. Following an episode of acute pancreatitis, patients are advised to avoid alcohol and tobacco consumption, high-fat foods and triglycerides, and medications that can put stress on the pancreas. As well, patients are encouraged to stay well hydrated and to eat a varied and healthy diet that is rich in fruits and vegetables.
Thank you for watching. Thank you so much. Excellent video. Thanks God, there are very nice sources in YouTube, and I hope we had these sources during my time and when I was in high school. We didn't have that. We have the library. We need to go physically to the library, get the books, and then return the books. You guys are so blessed with these resources in YouTube. Okay, so acute pancreatitis. It's a serious and at times life-threatening inflammation of the pancreas. This inflammatory process is caused by a premature activation of excessive pancreatic enzymes that destroy the ductal tissue and pancreatic cells, resulting in autodigestion and fibrosis on the pancreas. So those enzymes are lipase, protease, and amylase. So there is an overproduction, and these enzymes start attacking the pancreas, causing autodigestion. Okay. Pancreatitis can range from mild involvement evidenced by edema and inflammation to necrotizing hemorrhagic pancreatitis, which is a diffuse bleeding pancreatic tissues with fibrosis and tissue death. Pancreas is a serious condition. Actually, when a patient get a cancer in the pancreas, is most of the time is terminal. Okay, so you need to learn very good everything related to this organ. The pancreas is unusual in that it functions as both as exocrine gland and endocrine gland. The primary endocrine disorder is diabetes mellitus, right? Because remember the function of the pancreas to break down food and also to create hormones in order to lower or make balance in blood sugar in the body. So the exocrine function of the pancreas is responsible for secreting enzymes that assist in the breakdown of starches, proteins, and fat. We know that. In acute pancreatitis, four major pathophysiologic processes occur. Lipolysis, which is the breakdown of fats. Proteolysis, which is the breakdown of proteins. Necrosis of blood vessels, and inflammation. So the hallmark of pancreatic necrosis is enzymatic fat necrosis of the endocrine and exocrine cells of the pancreas caused by the enzyme lipase. Proteolysis involves the splitting of proteins by hydrolysis of the peptide bonds, resulting in the formation of smaller polypeptides. Dr. Matalana, this is too complicated. I don't understand what are you talking about. So first of all, proteolysis involves the splitting of proteins, means that the proteins are cut into small pieces. And how this happens? By hydrolysis of the peptide bonds, meaning hydrolysis of, let's think about the peptide bonds like glue. Okay, so they are going to hydrolyze, meaning that they are going to break down the water component in that glue that keep the protein together. So this is going to result in the formation of a smaller polypeptide. Dr. Matalana, what is polypeptides? The polypeptide describe a chain of more than 20 and less than 50 amino acids bound together via covalent peptide bonds. Singular amino acids are the building blocks of life. You have to think about amino acids are the blocks of life. So these are molecules that combine to form proteins. When amino acids come together, they form a protein, and they are the building blocks of life. So these amino acids, right, is going to become more than 20 and less than 50 when they are coming from the source of the polypeptides. Let me review the sentence so we make sense right now. So proteolysis involves the splitting of proteins, okay, to make them small, by hydrolysis, by breaking down the water of the peptide bonds. So the proteins are going to become very small because they are going to remove the water component that keep them together, resulting in the formation of smaller polypeptides. Polypeptides are multiple little pieces of amino acids, okay? Proteolytic activity may lead to thrombosis and gangrene of the pancreas. So since they are multiple pieces of proteins, these can cause thrombosis and gangrene of the pancreas. Elastase is activated by trypsin and causes elastic fibers of the blood vessels and ducts to dissolve. Dr. Matalana, what is elastase? Elastase is an enzyme from the class of proteases. Do you remember we talked about the three main important enzymes in the pancreas, lipase, amylase, and protease? Protease is breaking the proteins, right? So elastase is an enzyme from the class of proteases that break down proteins, okay? Okay, so elastase is activated by trypsin. Dr. Matalana, what is trypsin? Too many things, guys, you need to review. Oh my God, this is too much for my head. Trypsin is an enzyme in the first section of the small intestine that starts the digestion of protein molecules by cutting long chains of amino acids into smaller pieces. So we have many participants here, right? We have elastase, who is going to help in the breakdown of proteins. Then the protein is going to enter the first section of the small intestine, in which trypsin is going to start helping the digestion, right? So all these participants, if they are overwhelmed, if they are not working properly, they are going to cause maybe an imbalance in the enzyme activity. They are going to cause thrombosis, hemorrhage, and pancreatic tissue damage, okay? So many deaths in patients with acute pancreatitis result from irreversible hypovolemic shock due to hemorrhage. Think about it. With all these multiple activities from different participants and they are not working properly, then there's going to be a hemorrhage. Therefore, we are going to have hypovolemic shock. The inflammatory stage occurs when leukocytes cluster around the hemorrhagic and necrotic areas on the pancreas. And we remember that the leukocytes are a type of WBCs, right? Nurses love to monitor. Neutrophils are the most WBCs. Then you have the leukocytes, and then we have the monocytes, right? So a secondary bacterial invasion may lead to suppuration, pus formation of the pancreatic tissues called a pancreatic abscess. Okay, now this pancreatic abscess must be drained promptly to prevent sepsis. Of course, you have an infection inside that is causing a mass or an abscess. You need to drain it immediately to prevent sepsis, peritonitis, right? If the infected fluid becomes walled off by fibro tissue, a pancreatic pseudocyst forms. Okay, so here you have the process of autodigestion in acute pancreatitis. You are more than welcome to memorize this and to study and to analyze and to double check and whatever. Okay, very complicated graphic. Complication of acute pancreatitis. Acute pancreatitis may result in severe life-threatening complication. We know that. So we are going to have jaundice from the swelling of the head of the pancreas. Also, we can have the pancreatic pseudocyst, as we mentioned before. Maybe we are going to have intermittent hyperglycemia. Remember that this can be caused by the release of glucagon as well as the decreased release of insulin due to damage to the pancreatic islet cells. And remember that there is an exocrine activity and the endocrine activity. The endocrine is related to the enzymes, the hormones that are going to control the sugar, the glucose, right? And the exocrine is the breakdown, lipase, protease, and amylase. So then the total destruction of the pancreas may occur, leading to type 1 diabetes mellitus. Left lung pleural effusions frequently develop in the patient with acute pancreatitis. And what is pleural effusion? I'm sure you know this, but let me refresh. It's accumulation of excessive fluid in the pleural space, the potential space that surrounds each lung. Dr. Matalana, why you keep repeating concepts that I learned in previous semesters? Because with the amount of information you are learning in every single chapter, I am sure if you are not practicing and memorizing and doing NCLEX questions, at least 150 questions per week, okay, from different sources, all these concepts, you're going to forget them easily. So when we review the lecture, we take advantage. If we see a terminology, a concept that we can review, let's go and do it. It's going to be very helpful for you. Okay, multisystem organ failure is caused by necrotizing hemorrhagic pancreatitis. The patient is at risk for acute respiratory distress syndrome. This severe form of pulmonary edema is caused by disruption of the alveolar capillary membrane and a serious complication of acute pancreatitis. And remember, when we started this chapter, we said before I explain cholecystitis, that this biliary system, which is formed by the liver, the gallbladder, and the pancreas, okay, can cause refer pain in different organs. Okay, we spoke, for example, about pain in the right scapula as a symptom of cholecystitis, right? We were talking right now about a pain and different complications in the lung. When we were analyzing the bilirubin, we were talking about the participation and complications in the kidneys and the colon. So that's something that you need to keep in mind, okay? Coagulation defects are another major potential complication and may result in death. So disseminated intravascular coagulation involves hypercoagulation of the blood with consumption of clotting factors and the development of microthrombi. So the liver is basically making a participation in here, right? Shock in acute pancreatitis may occur. Hypovolemia, we spoke about that. That is coming with the hemorrhage, right? Also, paralytic ileus result from peritoneal irritation and seepage of pancreatic enzymes into the abdominal cavity. So etiology and genetic risk, the most common cause is by biliary tract disease. Again, liver, gallbladder, and pancreas, the biliary system, right? With gallstones accounting for a small half of the cause of obstructive pancreatitis. And you can have gallstones in the biliary duct, okay, that is coming from the gallbladder, or you can have little stones in the pancreatic duct, okay? So acute pancreatitis may occur as a result of trauma from surgical manipulation, after biliary tract, pancreatitis, gastric, or duodenal procedures. So you can get this pancreatitis for something different. You went for a procedure and they start manipulating different organs next to the pancreas, and now you're having acute pancreatitis. My strong recommendation whenever you are getting into any procedure related to the gastrointestinal, do it not in a place where there are multiple residents. You need a very experienced gastroenterologist surgeon to do this procedure, okay? Look for that. Okay, you can get acute pancreatitis from manipulation during cholecystectomy, the Whipple procedure, and partial gastrectomy. So what is the Whipple procedure? Also known as pancreatic duodenectomy, is a complex operation to remove the head of the pancreas, the first part of the intestine, which is the duodenum, the gallbladder, and the bile duct. So yes, I do have a video for this, and you are going to see this is not easy. It's a very complicated. They are not only removing the gallbladder, but also they are removing other parts of the biliary system. Let's watch this video.
Your pancreas is a long, slender organ that lies behind the stomach and intestines, near the spine. This delicate but vital gland is responsible for regulating your body's blood sugar with hormones, such as insulin, and for helping break down food with digestive enzymes. The pancreas is divided into 4 parts: the head, the neck, the body, and the tail. When cancer develops in the head of the pancreas, surgeons often utilize the Whipple procedure, also known as a pancreatoduodenectomy, to remove the cancerous and precancerous tissue from the pancreas. Before beginning a Whipple procedure, a patient is put under general anesthesia. Your surgeon will then make 1 or more incisions in the abdomen, depending upon the preferred approach: subcostal, midline, or through several small incisions, known as a laparoscopic or robot-assisted approach. Your surgeon will remove the head of the pancreas and a small segment of the intestine, along with the gallbladder and common bile duct. A classic version of the Whipple procedure includes the removal of the lower end of the stomach, known as the pylorus. The pylorus is a valve that controls the flow of food from the stomach to the intestines. The structure may be preserved when possible in a modification of the procedure known as a pylorus-preserving pancreatoduodenectomy. Especially large tumors may encroach upon nearby critical blood vessels that supply or drain the intestines. Reconstruction of the veins and arteries involved is technically challenging and is evaluated and performed on a case-by-case basis. Once the mass has been removed, your surgeon will begin reconstructing the digestive tract. A loop of small intestine will be connected directly to the pancreas, the common hepatic duct, and then the stomach. The Whipple procedure is very effective at eliminating cancer and abnormal tissue growth within the head of the pancreas. It is a major operation that usually takes up to 6 and often 8 hours. Most patients are fully recovered and back to daily life within a couple of weeks.
Thank you so much. So I am presenting this procedure, and as you can see, it could be a treatment, a surgery for acute pancreatitis as well as for cancer of the pancreas. Okay, it's the same technique. It's the same technique. Now I want you to think about it. I spoke during the gastrointestinal chapter when we were talking about the assessment of the GI, that there are different, the parts, how the pH varies depending on the section of the gastrointestinal, right? The pH in the esophagus, the pH in the stomach, the pH on the duodenum and the jejunum. So think about how this Whipple procedure can alter this pH alkaline status in the gastrointestinal. So this procedure could be very effective. However, if the patient is not following a strict diet, now that he is lacking some organs, many complications can occur. Okay, so what is better to prevent is to get away from alcohol, tobacco, foods high in fats. That's easy. As you can see through all these chapters in the GI, and also chapters that are coming later in the semester. We are going to talk about cancer in different organs. Alcohol, smoking, high fats, red meat. Okay, those are agents that we need to remove from our diet. Think about it. Okay, it's a homework for you guys. Okay, so basically we need to increase our intake of vegetables and fruits, right? Raw vegetables and food, and try to eat more organic, more fish, more water, less carbonated, less soda, okay? Less coffee, more natural teas, okay? try to get food that is not processed, food that is not in package, that has no label on it. Okay. Okay, so we spoke about the WIPA procedure. The trauma may also occur as a complication of the diagnostic procedure endoscopy retrograde cholangiopancreatography. Okay, we spoke about that procedure before in cholecystitis. So this acute pancreatitis, as you can see, has many causative agents that are not related sometimes by the pancreas itself, but are related to the manipulation that occurs when the patient is getting surgery or any treatment due to other conditions. Okay? Now, potential complications of acute pancreatitis, you have a long list. You have infection, hemorrhage, acute kidney failure, paralytic ileus. This is the gastrointestinal, right? Anything can cause paralytic ileus, hypovolemic shock, pleural effusion, acute respiratory distress syndrome. If we are having pleural effusion, of course, the lungs are going to be affected, atelectasis, pneumonia, multi-organ system failure, disseminated intravascular coagulation, remember the liver and the participation of all the clotting factors, type 2 diabetes mellitus. Incidence and prevalence. Pancreatic attacks are especially common during holidays and vacation because everybody is happy, drinking and smoking. When alcohol consumption may be high, especially in men. Women are affected most often after having cholelithiasis, meaning gallbladder stones and biliary tract problems. They are also most at risk for pancreatitis within several months after childbirth. The prognosis for recovery is usually good for pancreatitis associated with biliary tract disease, and poor if pancreatitis accompanies alcoholism. Let me repeat this. The prognosis for recovery is usually good for pancreatitis associated with biliary tract disease, meaning associated if there is something related to cholesterol that you can correct, right? But is poor if pancreatitis accompanies alcoholism. Okay? Okay, I think you got it. So, history, we're going to ask for abdominal pain, if it's related when the patient is drinking alcohol or eating a high-fat meal. We, of course, need to get a history of alcohol consumption, and you are going to use your old cards mnemonic, right, to ask for how long you have been drinking, this and that. If the patient also asks if the patient has a history of pancreatitis, trauma, or biliary tract disease. Factors that can cause acute pancreatitis, trauma, metabolic process like hyperlipidemia, is high intake of lipids, hyperparathyroidism or hypercalcemia, renal involvement, familial inherited pancreatitis, because everything starts with the family habits, viral infections, alcoholism, cigarette smoking, cystic fibrosis, gallstones, blah, blah, blah. So ask about other medical problems that cause pancreatitis. We spoke about the viral infections and the family history, and also ask what over-the-counter drugs the patient is taking, including nutritional and herbal supplements, okay? Now, the signs and symptoms. Typically, a patient is diagnosed after presented with severe abdominal pain in the mid-epigastric area or left upper quadrant. So this is different from cholecystitis. Cholecystitis is the upper right quadrant. We have the pancreatitis is the mid abdominal, mid-epigastric, or the upper left quadrant, okay? And let me review something else. Appendicitis is the right lower quadrant. Okay, so there you go. We are kind of reviewing the pain and the location. Assess the intensity and quality of pain. The patient often states that the pain had a sudden onset and radiates to the back, left flank, or left shoulder. So we are having the cholecystitis radiating to the scapula, the right shoulder, and is the upper right quadrant. And we have here the acute pancreatitis. The pain could be mid-epigastric on the left upper quadrant and is going to radiate to the left flank or left shoulder, okay? The pain is intense, boring, and continuous, and is worsened by lying in the supine position, okay? Often the patient finds relief by assuming the fetal position with the knees drawn up to the chest and the spine flexed, or by sitting upright and bending forward. Okay, he or she may report weight loss resulting from nausea and vomiting. Obtain patient weight. So we are going to see in the abdominal assessment generalized jaundice, and also we are going to see what we call the Cullen sign, the gray-blue discoloration of the abdomen and periumbilical area. Dr. Matalana, what is the Cullen sign? Here it is. Let me play the video so you can be familiarized when you see this presentation.
Cullen sign is often seen in severe pancreatitis, and it's characterized by periumbilical bruising and edema, and is caused by retroperitoneal bleeding.
Okay, so you have the Cullen sign over there, the mid-epigastric, this bruising, and then you have the gray-blue discoloration of the flanks, which is called the Gray-Turner sign. Let's play this video. So you have the Cullen, is the mid-epigastric, and then you have the Gray-Turner sign. Here it is.
Gray-Turner sign might be seen in severe pancreatitis and is characterized by flank bruising, and the cause of it is retroperitoneal hemorrhage that's tracked to the flank.
It's in the flank, okay? That's the Gray-Turner. And now you also are going to assess for bowel sounds. Absent or decreased bowel sounds usually indicate paralytic ileus, as I've been repeating the whole segment of gastrointestinal. On light palpation, note abdominal tenderness, rigidity, and guarding as a result of peritonitis. Pancreatic ascites creates a dull sound on percussion, okay? And auscultate for long fills for adventitious sounds or diminished breath sounds, and observe for dyspnea and orthopnea. And that's good to know. NCLEX alert. In acute pancreatitis, auscultate the long fills for adventitious sounds. That's very important. Now, critical rescue, monitor for significant changes in vital signs that may indicate the life-threatening complication of shock. Hypotension and tachycardia may result from pancreatic hemorrhage. Excessive fluid volume shifting or the toxic effects of abdominal sepsis from enzyme damage. Observe for changes in behavior and level of consciousness. Of course, if we have a patient that is having hypotension and tachycardia. Psychological, psychosocial assessment. If excessive alcohol is a causative factor, tactfully explore the patient alcohol intake history after the patient has adequate pain control, and you can use the CAGE questionnaire to assess for this. And I am submitting this CAGE questionnaire in the supplemental material that is ready for you to use. with every chapter. I am submitting the links of these videos, the videos that I'm using on these videos, and also any extra website or any good material for you to study. So the CAGE questionnaire is C. Have you ever felt you should cut down on your drinking? The A is, have people annoy you by criticizing your drinking? G would be, have you ever felt guilty about drinking? And E is, have you ever had an eye opener drink in the morning to steady your nerves or to get rid of a hangover? So that's the CAGE questionnaire, okay, that you need to assess. After you make sure the pain is under control, then you conduct your verbal assessment, okay? You don't want to torture the patient with these questions if the patient is still having pain. Causes of serum laboratory abnormalities in acute pancreatitis. Basically, you are going to see all the enzymes, the amylase, lipase, trypsin and elastase. They are going to be elevated, increased, and this is telling you that there is a pancreatic cell injury going on. Elevated glucose and decreased calcium and magnesium, and this is due to fatty acids combined with calcium seen in fat necrosis. Do you remember when we talk about the fat embolism syndrome, why the calcium decreases? Because it's combined with fat. It's similar to this one, okay? So important to know, decreased calcium when taking the BP of a patient with severe pancreatitis. There is one sign called the Trousseau sign, and this one will help you if you're going to be a ER nurse and you have a patient with mid epigastric or left upper quadrant pain and you are taking the blood pressure, and if you see this with those three without reviewing, analyzing your blood work, you can think about hypocalcemia, and probably you are going to be in good scenario to diagnose
Trousseau sign is a clinical manifestation of
acute pancreatitis. It is called Trousseau sign.
hypocalcemia that is more sensitive than Trostick sign. To elicit Trousseau sign, occlude the brachial artery using a blood pressure cuff. The lack of blood flow exacerbates the existing calcium deficiency in the neuromuscular tissues of the distal arm, causing spasms of the hand and forearm muscles. This leads to wrist and metacarpophalangeal joint flexion, proximal and distal interphalangeal joint extension, and finger adduction. As we occlude the blood vessel, notice the patient's hand turning upward and inward, inflection and adduction.
That's the Trousseau sign, okay? So laboratory, there are many symptoms. You see, you are in ER, the patient is coming with abdominal mid-epigastric pain, left upper quadrant pain. You assess the abdomen, you find your Cullen sign, which is the bruises in the abdomen below the umbilicus, and then you find your Gray Turner, which is the decoloration on the flanks, and then you take your blood pressure and you see the Trousseau sign. So you're in good shape. You can tell the doctor, I highly suspect this patient is having acute pancreatitis. Okay, laboratory assessment. You're going to find the amylase level usually increase. I think this is a more descriptive version of whatever we saw on the previous table. Let's move to imaging assessment. The abdominal ultrasound is the most sensitive test to diagnose causes of pancreatitis, such as gallstone, and can be performed at the bedside. However, it's not helpful in viewing the pancreas because of overlying bowel gas. So in these cases, they are going to use the CT scan with contrast, and they also going to rule out pancreatic pseudocyst or ductal calculi. There is also an abdominal X-ray which can reveal gallstones. X-ray, chest X-ray may show elevation of the left side of the diaphragm or pleural effusion. This is very important. Pancreatic stones are best diagnosed through ERCP, which we presented and described and saw the video before. So we have an NCLEX question. A client was admitted to the hospital yesterday with a diagnosis of acute pancreatitis. What assessment findings will the nurse expect for this client? Select all that apply. So the patient is going to have the severe boring abdominal pain, is going to have the jaundice, nausea and vomiting, leukocytosis, which is the increase in WBCs, dyspnea because the pancreas is going to make a discomfort, it's going to cause alteration in the diaphragm, right? Decreased serum amylase is not the option because in this case would be increased elevated serum amylase. So what are we going to do? We're going to manage the pain. As for any patient, continually assess for and support the ABCs first, airway, breathing, and circulation. Remember the effect of the inflammation, the pancreatitis, and how this causes deformity, let's say, no, right, in the diaphragm and the space of the left lung. In collaboration with the temporary therapies, if available, provide oxygen and other respiratory support as needed. Severe continuous boring abdominal pain, we are going to see in this patient presentation. We have to assess pain very often. Non-surgical management. Mild pancreatitis require hydration with IV fluids, pain control, and drug therapy. So that's the standard. You control the pain, the IV fluids with drug therapy. Non-surgical interventions include fasting and rest, drug therapy, and comfort measures to rest the pancreas and reduce pancreatic enzyme secretion with whole food and fluids MPO during the acute period. Because remember, all these enzymes that helps to break down the food, amylase, lipase, and protease, are going to be overactive. So we need to keep the patient MPO, nothing per oral, and just try to reduce the inflammation, and the patient just need to be hydrated. The primary healthcare provider prescribe IV isotonic fluid administration to maintain hydration. IV replacement of calcium and magnesium may also be needed. Remember that this acute pancreatitis is going to present with decreased calcium and magnesium, and that's good to know. Okay, that's good to know. You need to know your electrolytes. Nasogastric drainage and suction are reserved for more severely ill patients who have continuous vomiting and biliary obstruction. Gastric decompression using a nasogastric tube prevents gastric juices from flowing into the duodenum. So this is good to know too. The NG tube usually is placed to decrease the release of pancreatic enzymes into the pancreas and decrease pain. So we know the NG tube is working when the pain is decreased, right? That's good to know. And then we have safety priority because paralytic ileus is a common complication of acute pancreatitis. Prolonged nasogastric intubation may be necessary. Assess frequently for the return of peristalsis by asking the patient if he or she has past flatus, right? That's one way to assess. Or had a stool. The return of bowel sounds is not reliable as an indicator of peristalsis return. Passage of flatus or a bowel movement is the most reliable indicator. And that's something that I really want to emphasize. Sometimes we understand that the bowel is working properly when we see a stool bowel movement, right? But the most reliable indicator is passage of flatus. I'm sorry, I need to correct this, but sometimes we believe that the vowel sounds are the most reliable indicator that the system is working properly, but it's not. It's the vowel movement and the flatus, okay? So pain management, this patient is going to be given morphine and hydromorphine to treat the pain. In mild pancreatitis, the pain usually subsides in 2 to 3 days. However, with severe acute pancreatitis, the abdominal pain and tenderness may persist for us to after 2 weeks. And I've seen these patients, they are having a miserable hospital stay there with this severe acute pancreatitis. Histamine receptor antagonists, famotidine, and proton pump inhibitors, your pantoprazole, help decrease gastric acid secretion. Also, antibiotics may be prescribed, but they are indicated primarily for patients with acute necrotizing pancreatitis or pancreatic abscess. Helping the patient, assume a side-lying position with the legs drawn up to the chest may help decrease the abdominal pain of pancreatitis, the fetal position, right? Sitting with the knees flexed toward the chest is also helpful. If the patient is NPO or has an NG tube, remind assistive personnel to implement frequent oral and nurse hygiene measures. I really think this is not necessary to mention, but it's common sense, but it's good to know. Action alert for the patient with acute pancreatitis, monitor his or her respiratory status every 4 to 8 hours because of pleural effusion. Fluid overload can be detected by assessing for weight gain, crackles. So you need to do a very thorough respiratory assessment. Observe for signs and symptoms of hypocalcemia. So that's going to be your Trousseau sign. If pancreatitis was caused by gallstone and ERCP with a sphincterectomy, opening of the sphincter of Oddi. We know the sphincter of Oddi is the one that is the entrance to the duodenum, may be performed on an urgent or emergent basis. Now, surgical management, they are going to, what happened? Okay. So surgical management, if an ERCP is not successful in removing the gallstone, a laparoscopic cholecystectomy may be performed. Pancreatic pseudocyst and abscess may also require surgical intervention, and laparoscopy could be one of the choices, right? Promoting nutrition, the patient is maintain NPO status in the early stages. Is going to be given antiemetics for nausea and vomiting, basically symptoms, support of the symptoms. The patients that are having a severe pancreatitis and are unable to eat for 24 to 48 hours after illness onset may begin jejunal tube feeding unless paralytic ileus is present. So they would be enteral feeding, okay? Enteral because it's through the gastrointestinal, through the jejunum. So enteral feeding is preferred over total parental nutrition because it causes fewer episodes of glucose elevation. Remember that the parental goes straight to the circulatory system, and this could increase the glucose elevation. And you have to weigh the patient every day. When food is tolerated during the healing phase, the primary healthcare provider prescribes small, frequent, moderate to high carbohydrate, high protein, low fat meals because the metabolic needs, right? So it's going to be high carbs, high protein, low fat. and food should be bland. GI stimulants such as caffeine containing food, tea, coffee, cola, and chocolate, as well as alcohol, should be avoided. I'm going to highlight this in other colors so you know that the patient in recovery of acute pancreatitis should avoid caffeine containing food, tea, coffee, cola, chocolate, as well as alcohol, okay? And then you keep monitoring the patient so the transition to normal food can be done. And as of course, you're going to assess for vomiting, diarrhea, nausea. The healthcare provider may also prescribe fat soluble and other vitamin and mineral replacement, glutamine, omega-3 fatty acids, fiber, antioxidant, and or nucleotides may be added to the patient nutrition plan. If the patient is going to get omega-3, make sure that you already assess the bleeding status, okay? And because some of these supplements can cause bleeding or may increase bleeding, so make sure the patient is not bleeding. Self-management education. If the patient uses alcohol, instruct him to abstain from drinking. We don't need even to mention this because we know the causative agent. Teach the patient to notify the primary healthcare provider after discharge to home if acute abdominal pain or biliary tract disease as evidenced by jaundice, clay color stools, or dark urine occurs. So when the patient goes home, double check on jaundice, the clay colored stools, or darkened urine occurs. And that's it. Basically, we need to control the abdominal pain and we need to provide guidance and education for adequate nutrition available to meet metabolic needs. When we come back, we are going to talk about chronic pancreatitis. Thank you very much. Stay tuned.